بسم الله الرحمن الرحيم. السلام عليكم. أنا محمد ضفع الله، اختصاصي الباطنية والغدد الصماء. مرحبا بكم في الكليركشيب سيريز. الليلة حنقدم كيس حتكون interesting كيس، حاجة very common بنشوفها في الكلينيكال براكتس، في الامرجنسي روم، وفي حتى في الاوت بيشنت ديبارتمنتس. عايز كل شخص يكون بيحضر في الفيديو يقرأ معايا الكيس. إذا احتجت تقراها بسرعة أبطأ شوية وقف الفيديو وأقرأ عليه راحتك أو أقرأ عليه راحتك، وبعد كده واصل الفيديو. في أثناء الفيديو حيكون في أسئلة، فهطلب من الناس إنه توقف الفيديو عشان تقرأ السؤال، تفكر في الإجابة، وربما تدون الإجابة، وبعد كده تعمل ريستارت للفيديو وتتابع معانا عشان نشوف الإجابة هل بتطابق الإجابة اللي طلعت بها ولا في اختلاف، عشان التعليم يكون أفضل. فنبدأ الكيس. Okay. So the chief complaint is right-handed weakness and difficulty speaking. Okay, so HPI, this is a 68-year-old taxi driver. He was brought by a friend after he noticed the patient to have difficulty speaking. فصديق سائق التاكسي حس إنه البيشنت عنده difficulty speaking. He says that they were drinking tea together when the patient dropped his cup. When he asked him what's wrong, the patient was unable to answer him. The patient says that the symptoms have improved, but while on their way to the hospital, he was unable to speak or grasp any items. He denied headache, vision loss, lower limb weakness, involuntary movements, or recent falls. His friend says that he has not noticed any changes in the level of consciousness in the patient. When asked whether a similar condition occurred in the past, the patient admitted to once losing vision temporarily while driving, but luckily enough, he was driving slowly and did not get into any accidents. He was very lucky. Okay, so in a question, so what pertinent information would you like to obtain in the medical, surgical, family and social history؟ يعني باختصار عايز أعرف ياتو أسئلة حتكون عايز تسألها، أو ياتو نوع من الأسئلة حتكون عايزة تسأليها في باقي الهيستوري. pause the video, think about your answer before proceeding forward. Okay, and let's see what we have obtained from this patient's history forward. So in review of systems, CNS, we start with the system that is involved. So we think it's the CNS. So as previously mentioned in the HPI, these were the symptoms. He didn't have any other symptoms. Cardiovascular wise, he denies chest pain, palpitations, or lightheadedness. Chest or lung, he does not have any cough, wheezing, or shortness of breath. GI, there has occasional heartburn, but otherwise it's negative. So no diarrhea, no constipation or otherwise. Musculoskeletal and skin, he has bilateral knee discomfort. There's no worrisome skin changes that he has noticed. GU or genitourinary, he has difficulty in initiating urination and increased urination frequency or frequency of urination. In his past medical history, he has uncontrolled hypertension for the past 22 years and he has osteoarthritis. Past surgical history is none. Family history, his brother died of lung cancer 3 years ago. He's unsure about his maternal and paternal family history. And we find this a lot in a lot of patients. يعني كثير من المرضى بيكونوا يقول لك أنا مثلا أبوي مات فجأة ما عارفين السبب شنو، أو كان عنده مرض لكن ما عارفينه، أو مرات بيألفوا diseases لكن هم بيكونوا ما متأكدين، لكن في بعض الأحيان بيكونوا عارفين ومتأكدين. Okay, social history, he's a former 46-pack year smoker. He quit after his brother died. So he was a chronic smoker, but once his brother died from lung cancer, he quit smoking. And this was about 3 years ago. At home, he takes amlodipine 5 milligrams daily and aspirin 100 milligrams daily. Okay. So another question, what physical exam findings would you expect in this patient? Again, pause the video and think about the answer. وقف الفيديو وفكر في الإجابة قبل ما نواصل. Okay, let's see what the physical examination findings show. So vital signs, and we like to start with vital signs because they are vital. Blood pressure is 166 over 98 millimeter mercury. Heart rate is 82 per minute. Respiratory rate is 16 per minute. Temperature is 37.6 Celsius. In general examination, he appears worried, but he is not in any distress. Uh, and by distress, we mean respiratory distress or painful distress, but he does appear worried. HENT or head, ears, eyes, neck, or sorry, nose and throat. There is slight droop in the right corner of his mouth. There is arcus cornealis, which is also named arcus senalis by some authors, or arcus senalis. There is no evidence of head trauma. His neck is supple, meaning that he can move his neck easily without any stiffness or pain. There is left carotid bruit. Chest examination shows slight increased in anterior-posterior chest contour. So he has what we call barrel-shaped chest. Barrel-shaped chest. It's common in those who have emphysema. Normal vesicular breath sounds are heard bilaterally. In cardiovascular exam, he has a regular rhythm. His apex is in the left sixth intercostal space, and it's laterally displaced. So it's laterally displaced to the mid-clavicular line. He has a normal S1 and S2, and he has an audible fourth heart sound. This means that he has some pressure overload. So patients with hypertension commonly have, sometimes have a, not commonly, but sometimes they have a fourth heart sound that's audible. So you can go back to your cardiovascular physical examination and read about what the implications of a fourth heart sound are, what is a fourth heart sound, and what are the implications of a fourth heart sound. But he has no murmur. GI, he has normal bowel sounds. There is no tenderness, organomegaly, or any masses that were felt. CNS examination, his Glasgow Coma scale is 15 out of 15, meaning that he is alert. His cranial nerve 2 through 12 were grossly intact. I wouldn't say that they were fully normal because he has a slight droop in the right corner of his mouth. That means the seventh cranial nerve is probably affected to some extent, but maybe when he actively moves his mouth, and you know that it might be normal. But here they mentioned that it's grossly intact. So I doubt that this is actually true. Normal muscle tone in all extremities. His power is slightly reduced, 4 plus over 5, but he has normal deep tendon reflexes. Okay, so think about the differential diagnosis and what this patient might have. Again, this is someone who came with aphasia and right arm weakness and some facial droop. By the time he came to the hospital, these symptoms have resolved. So think about the differential diagnosis that is there. Pause the video, think about it, and resume again. Okay, so let's see what the differential diagnosis is. So here it's either a TIA or a transient ischemic attack, or maybe he has a minor stroke. Okay, less likely are partial seizure with post-ictal paralysis, maybe multiple sclerosis. He's older, so this is less likely, but it can happen. Or a subdural hematoma given his age, but he does not have any evidence of any head trauma or anything like that. But again, you should keep it in your differential diagnosis. Okay, so these are some symptoms, common symptoms that might suggest TIA. So the patient has focal, cerebral, or retinal symptoms lasting for seconds or minutes, typically less than 1 hour, or if the patient has motor weakness in the limbs or on the face, if there is sensory deficit, or if there is visual defects such as homonymous hemanopia or monoocular blindness, if the patient has aphasia or dysarthria. So these are most likely the symptoms of TIA. Other things that might suggest a TIA, or a possible TIA, are some things like unsteady gait or diplopia, vertigo, dizziness, dysphagia. So these are all can be neurologic symptoms, but they can also be symptoms of other etiologies. Things that are not usually TIA, things are like amnesia or forgetfulness, confusion, incoordination of the limbs, partial sensory deficit, or unusual cortical visual symptoms such as lone bilateral blindness and bilateral positive visual phenomena. It's a transient a transient loss of consciousness, headaches, things like phosphenes, photopsias, or complex visual hallucinations and palinopsias. These usually are not features of TIAs. So the things that are suggestive of TIAs are these things here, and he has two of these things. So he has aphasia and he has some motor weakness in one limb and the face, which was transient. Okay, so let's go through some definitions. There is an entity called amaurosis fugax, in which there is transient monoocular blindness that is often described as a gray shade being pulled down over the eye caused by ischemia to the retinal artery. So this patient might have had this amaurosis fugax before. He had monoocular blindness. He thought that he was completely blind, maybe. But usually the patient describes it as if someone is pulling down a curtain um, or a gray shade, and because there is ischemia to the retinal artery, and so the retina isn't supplied by blood, and so they get this monoocular blindness. A stroke, as we know, is an acute onset of focal neurologic deficit due to cerebral infarction or hemorrhage. A TIA is transient neurologic deficit due to ischemia in an identified vascular territory without ischemic lesion visible on brain imaging. Now, in the past, they used to call a TIA any transient neurological deficit that lasts less than 24 hours, but now the definition is that you have to have no visible lesion on brain imaging. So if there is a visible lesion on brain imaging, we call it a stroke. So this is the new definition. Okay, so another question. What laboratory and imaging tests would you like to obtain at this time? And what is your treatment plan? So pause the video, think about your answer very well, and then resume the video. Okay, so let's see what the treatment plan or the laboratory investigations were for this patient. So they did a lipid profile. The total cholesterol, it was 188. His LDL was slightly elevated, 140, and his HDL was low at 34. Triglycerides were normal at 70. His hemoglobin was slightly low, 11.2. His calcium is normal because his albumin is 4.1, so calcium is normal. A1C is 6.1, so he's pre-diabetic, and his estimated GFR is 43. Now, this patient has hypertension. We expect that he might have some reduced GFR. If you test the creatinine, it won't let you know what the GFR, what the level of kidney function is. You need the GFR. So if you're not given the GFR, you can use calculators to calculate the patient's GFR. You'll need the patient's height and his creatinine level and some other things. But keep in mind that most of these calculators are built to assess for chronic kidney disease, not acute kidney disease. Okay, so his ECG was done, also was normal sinus rhythm. There was some voltage criteria for left ventricular hypertrophy. They did a CT brain without contrast, and it was reported as there was chronic small vessel ischemic changes, generalized brain atrophy, which was appropriate for his age, and there was no evidence of infarction or hemorrhage. So apart from these chronic small vessel ischemic changes, he doesn't have any acute issues that can be seen on CT. Now, they ordered an MRI, but it's not available, and such is the case in many centers. But if you get an MRI, that would be ideal to see if there is any acute ischemic changes. Now, a CT you want to do first because it will show you if there is any evidence of hemorrhage. But if you have MRI capabilities, you go ahead and get an MRI to show you if there is any acute changes. Sometimes it's difficult to assess for ischemic changes using a CT if it's been, the symptoms have occurred very recently. So they also did a carotid duplex or a carotid Doppler, which showed bilateral carotid artery stenosis. On the left side, 75% and 72 in the right side. So this patient has several risk factors for atherosclerosis of his carotid artery, including smoking history, uncontrolled hypertension, and this pre-diabetes, which is not a big deal, but it's something to take into consideration. But mainly, it's probably going to be the uncontrolled hypertension and the smoking in this patient. Also, age is an important factor, and family history as well. Okay, so the treatment plan, so they gave him aspirin loading dose, 300 milligrams, and it's usually chewed. They ask the patient to chew the aspirin, followed by 100 milligrams daily of aspirin immediately after exclusion of hemorrhage. So you need to get a CT of the brain, and then you give the patient the aspirin. It doesn't necessarily need to be chewed, but chewing will make the aspirin be absorbed quickly, and it will bypass the first pass metabolism done by the liver. So and then you follow it with 100 milligrams daily, but you have to exclude hemorrhage first. Next, he was given clopidogrel 300 milligrams once as a loading dose, followed by 75 milligrams daily for 21 days. So these are newer guidelines that recommend giving 75 milligrams daily for 21 days along with the aspirin, but you have to load the patient with clopidogrel 300 milligrams. Okay, so then they controlled the hypertension. So they added a second hypertensive agent. They added an ACE inhibitor. He has some left ventricular hypertrophy. So the ACE inhibitor will help with the remodeling of the left ventricle as well. So, and it's a good antihypertensive agent. His kidney functions aren't bad enough for him not to get an ACE inhibitor. This is a good choice in this patient. So then he was started on high intensity statin, atorvastatin 40 or 80 milligrams. Another choice is rosuvastatin, 20 to 40 milligrams. So you can choose either or. These are high intensity statins. At these doses, they call them high intensity statins. So what do we mean by high intensity statin? Meaning that they lower the LDL, which here was 140. They lower the LDL by 50%. So in about 2 or 3 months, we expect the LDL to be somewhat about 70 or so. If it's more than that, either the patient is non-compliant or he's just not tolerating it well enough. Maybe we need to increase the dose or maybe add a second agent if necessary. Then we institute a DASH diet, or we call it the dietary adjustment for something with hypertension. I don't recall the exact what the acronym stands for, but it's usually given to as a reduced salt diet, fatty foods and dairy. So we reduce these things and they increase the vegetables and the legumes. يعني الحبوب نزيد الحبوب والخضروات. This is the dietary change for those with hypertension. And then you engage the patient in a supervised exercise program. You don't tell the patient ما بتقول العيان go ahead and exercise طوالي من البداية. He just recovered from a TIA, perhaps even a stroke because we don't have any MRI imaging. He has left ventricular hypertrophy, so you don't want to just go ahead and send them to do exercise, but it has to be supervised in order for this patient not to get into some acute complications from an aggressive exercise program. And then discuss at least temporarily stopping driving. يعني هو كان محظوظ إنه كان سايق بالراحة المرة اللي فاتت وما حصل له حادث بسبب الأميروسيس فيوكاكس. But at this level, maybe he shouldn't drive anymore because he can have a stroke while driving, and then he'll get into a big accident and perhaps lose his life. So this should be an issue that should be discussed and not forgotten. Although some patients بيقول لك يعني this is my only lifeline, يعني ما عندي طريقة تانية يعني. Okay. So next, surgical management, because he has a bilateral carotid stenosis, more than 70% here, both sides. So they sent him to do an endarterectomy. You want to send the patient to a center with very low surgical morbidity and mortality if his surgical risk is low. So إذا عملوا له surgical risk assessment, they think his surgical risk is good enough, then they can send him for carotid endarterectomy. يعني باختصار يشيلوا الاثيروسكلروسس القاعد في الكاروتيد artery عشان to put him at less risk for a bigger stroke or even a stroke if this is a TIA, to put him to a lower risk. When do we do this carotid endarterectomy? We'll talk about it in a minute, but think about this question until we get to that point. Okay, so we know the patient needs the surgery, but when should the surgery be done? As I mentioned, it should be done as soon as possible because the risk of stroke is highest in the few hours to days after the TIA. وهو جاته TIA هسي, he is highest at risk of getting a stroke في الأيام الجاية. يعني this is based on a few studies. لقوا إنه الناس اللي بتجون TIA في خلال الأيام البسيطة اللي بعدها مرات بتجون stroke ومرات بتكون very big stroke. عشان كده you need to do this treatment as soon as possible, this carotid endarterectomy. Okay, so this is a flow diagram showing how we manage patients with the TIA. So if you had a patient has a transient neurologic symptoms with no persistent deficit, you should seek medical attention and take aspirin 300 milligrams. فعادة بنقول للعيان ياخدوا لكم 3 حبات بتاعت aspirin 100 milligrams, and then امشوا ل TIA clinic أو امشوا ل emergency department. Okay, so first you do a history and you do a quick exam, and then you can determine the ABCD2 score, and this is optional, you don't have to do it. تعمل 12 lead ECG, تاخده في تليمتري أو تعمله هولتر ECG عشان إذا عنده atrial fibrillation أو حاجة زي دي you can catch it. مرات بيجوا ب transient atrial fibrillation, you don't catch it on the 12 lead EKG أو 12 lead ECG. فالهولتر مونيتور او التليمتري بيكشف لك طوال. التليمتري هو continuous ECG. Okay, you determine laboratory values for C-reactive protein and ESR إذا هو عنده any inflammatory disorder that put them at risk for developing strokes, and this is something that we'll talk about in another session, but some form of vasculitis can cause atherosclerosis, or sorry, strokes. So we'll leave that to the next session or the following session that we have. And then if the patient didn't take aspirin, you give them the 300 milligram loading dose. You get an MRI and DWI, which is diffusion weighted scan, diffusion weighted imaging of the brain on arrival. If you don't have this, you just go do a head CT. Okay. If the DWI or the diffusion weighted imaging is positive, there is brain infarction or there is infarction indicated by a bright white spot or spots. This is probably a minor stroke. If it's normal, it's most likely a TIA. عشان كده قلنا إنه الدايجنوسيس بتاع TIA بقى ما بس بالسيمتومز، بقى الإيمجينج برضه مهم جدا عشان تعرف إنه دي minor stroke ولا TIA. مرات بيكون في حاجات TIA mimics بتشبه TIA لكن ما TIA. Okay. You can pause the video to look at these if you want. Okay, so you think it's a TIA because the MRI was normal or the DWI was normal. What do you do next? You give a loading dose of clopidogrel, and then you evaluate the cause. So if it's vascular, you do such as a neck ultrasound. You can do a head and neck CT or magnetic resonance angiography عشان تشوف vessels, posterior vessels والanterior vessels في circle of Willis. You do telemetry زي ما قلنا, and then you can consider doing a transthoracic or transesophageal a transthoracic echocardiogram عشان تشوف إذا عنده intracardiac thrombus. إذا الترانستوراسيك ظهر لك حاجة لكن ما متأكد, ممكن تعمل transesophageal echocardiogram, الصورة فيها بتكون أوضح شوية. And then you can do tests to detect any SVD, such as MRI of the brain, you do flare imaging, you do all sides of imaging to see if there is any if there is any small vessel disease. So if there is any one or several small deep infarcts, you go through these things here to see if there is any small infarcts or bleeding, and you discharge them with treatment medical therapy. إذا عنده مثلا اكتشفت عنده atrial fibrillation أو حاجة زي دي, you also do medical therapy for this, and they might even need ablation if there is a focus. And if there is no cardiac disease, you give them medical therapy. If there is any atherosclerosis or any stenosis of the internal carotid artery, if it's more than 50%, you should do endarterectomy. And all these patients need medical therapy at the end. Okay, so what is medical therapy? You give them clopidogrel 75 milligrams, that aspirin, for 21 days, and you manage the risk factors. If they are diabetic, you treat the diabetes, you lower the cholesterol to less than 70 milligram per deciliter, smoking cessation, physical exercise, and counseling regarding diet. And I would include things like depending on their job, زي العيان بتاعنا عنده هو يعني سواق تاكسي, maybe he will get into an accident if he has another stroke. Okay, so this is the end of the session. I hope it was useful. If you have any questions, please leave them in the comments. Thank you and good luck.